I'm Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and you are listening to JAMA AI Conversations. My guests today are Dr. Jonathen Chen, Assistant Professor of Medicine at Stanford University, and Dr. Ethan Goh, a postdoctoral scholar at Stanford University. Let me first ask, how did you two start working together? And I know that your work emphasizes kind of the integration of human and artificial intelligence to enhance clinical decision making. So, can you tell me how you started working together?
Yeah, I'd love to take that question. Thank you for the introduction. So I got to know John because I was doing a master's program at Stanford. It was a clinical informatics and management program. John was a guest speaker. He came to give one of his classic talks around data mining and how it could improve the outcomes and qualities of decision making. And I was an internal medicine doctor myself, had toyed in a bit of technology innovation, contributed towards the building of a Q&A platform. And I was basically blown away, right, by what John was coming to share of, hey, how you could use data to basically improve decisions of doctors as well as outcomes of patients. So that's how I came to connect with John. And I think over the years, we've worked together for about 2 years now on a lot of the pieces you mentioned.
I love hearing about that. That's how most people discover research is through presentations and talks. So, Jonathen, can you tell me then about how you started in this research area and also what made you bring Ethan onto your team?
Yeah, I mean, I have a PhD in computer science. I was a software developer many years ago. So I've been looking for the combination of computers and medicine for 20 plus years, back when I was a medical student. And they made us remember 100 bugs and 100 drugs. I'm like, this is clearly not a good use of a human time. This is so much clearly a computer could do this better. So I've been looking for those combinations all along. For this particular study that we're going to end up focusing on, a lot of it really was like, holy smokes, right? Disruptive technology showed up less than 2 years ago. ChatGPT arrives on the scene like, whoa, these large language models are a lot more robust than many people would expected. Even though I've been studying recommender algorithms, informatics, data science, and medicine for literally over a decade at this point. And wow, when this tech came out, it's like, I think this just leapfrogged half my research program. We really need to rethink how we integrate and use these, which means we need a much more deliberate way to study and evaluate them as well. Because multiple choice questions are easy to study, but are just mean nothing in the context of real medicine. So we want to do a very deliberate study in a rigorous way to evaluate that. Ethan came via the Clinical Excellence Research Center. He was applying for a program with Arnie Milstein. And Arnie, he just pulled me aside as, Jonathan, look at this guy's resume. We should really find a way to connect with him. And so Arnie really made that great contact. And it's ended up being a very effective, very productive working relationship together that I think we're both learning a lot from each other. And that is the best kind of synergy, just like AI and medicine should be. When we can each do things the other can, we're all better off.
And Jonathan, let me touch on the point that you have been doing this for over a decade in terms of computer science. So have you just been waiting for this to come along?
Sure, it's perhaps ironically my most cited paper is actually a perspective I wrote about the hype of machine learning in medicine. And it's got far more actually citations than my primary research articles, just because I had this very provocative notion. I've been studying these types of technologies for decades. And in the 1980s, a rule-based system, if this, then that, if fever, then predict sepsis, that's AI, and that's actually really good. Actually, we use it in our systems right now. We just don't think of it that way. The last wave, there's computer vision, and then there's machine learning. Can you predict the risk you'll have a stroke or get readmitted to the hospital? It's very hard for a human to calculate those things. You can do much more deliberate, data-driven approaches. But here are now these like language models, these chatbot type style things. Prior generation was actually really bad. They were just unusable. I had students working on this 5 years ago. Let's see if a chatbot can answer medical questions 5 years ago, and it was getting 35% accuracy. That was a fun little class project. That was unusable. It was not worth paying attention to. But the pace of technology has moved very rapidly. And this time, unlike a lot of cool tools we've had for many decades that are very good, whoa, this I think really changes the way everybody lives their life and does their work.
So now why don't we talk about the paper then? Because we do see some really interesting results. And actually one of them being that I think LLMs alone did actually quite well. So do you think there's going to be this type of replacement of providers?
When we did the study, the results are not what we expected. Describing briefly this study, complex diagnostic vignettes, it's not simple multiple choice. It's give your differential, explain your reasoning, justify what the pros and cons. Very complex question that actually you need human expert graders to even give you a clean answer. But we prospectively did it, pre-registered clinical trials like a randomized study to be as rigorous as possible. In our pilot study, we thought the docs who had access to the chatbot were going to do way better than the docs who only had access to the usual internet, up-to-date PubMed, Google, whatever it may be. And then when we actually did the randomized study, that didn't turn out to be the case, which is not what we expected, which is really weird because the chatbot by itself, you can just copy and paste in the question and it'll give you an answer that can be graded and is surprisingly better than all of the doctors, including the doctors who had access to the chatbot. It was just very weird. There's very flies in the face of the fundamental theorem of informatics. Human plus computer, when combined, will deliver better results than either would alone. Sounds so good, right? I've been saying that as my last line of my talks for years, and I don't say that anymore because results like these are kind of challenging. Like, whoa, what's going on? Why did this happen, and what does this mean towards how we think about these tools and how we practice medicine in the future? And I'd love to have Ethan give a comment on what his perspective of what he thinks these results mean.
Yeah, I think I have two initial reactions. Again, within our study design, there were already a lot of other studies that had, in an easier method, showed, hey, medical students, MCQ exams, just run some sort of API to grade it. So I think as clinicians, we're like, hang on, that is not really representative because, medicine is not patient comes in, A, B, C, D, what's the right option? And so I think within that, we really try to round up a very robust group of clinical educators, professors to say, hey, what could be a better structure, right? And so, for example, our questions, they were open-ended. There was not like, hey, you give A, B, C, D, you get that score, right? It was kind of a consensus-based rubric, meaning to say that we tried our best to have a very robust representation, while granted it was still in a simulated environment, right? So that was the first piece. And yeah, that made, what we found all the more astonishing. Like, hey, AI alone actually still did really, really well, right? On not a very simple multiple choice question exam. And I think my second reaction to your question on whether AI alone or AI whatever is going to replace, I think that it is indeed the results speak for where the next phase of research should be headed. I think there's going to be a lot of interest, excitement around, okay, now we know that AI and doctors don't actually do that well, right? AI alone does that well by itself. What would be the best way to create this sort of tools? And indeed, that's a lot of threads our research group is working on. For now, we know these tools can do quite well. What is the best way to combine it and use it as a tool for doctors? So I think those are great questions.
So then let me ask you, what did you want to add to the study? Was there anything missing in the study, Ethan, that you would have wanted to do? And I guess that's the next question of what is your next study now that you have these results?
Yeah, I think to that point, we are actually working with collaborators to try and figure out a chatbot. This idea of who goes first, Eric Horvitz at Microsoft many years ago had already been working on this thread, which is should an AI give a response first or should a human doctor, right, give a response and critique? So that's one example of how we're trying to design these tools and study what would be the best way for human plus AI to work together. So that's one active thread that we're excited about. I think John mentioned there were all these recommended tools, which speaks to more predictive technology because you can say, hey, and compare it against what doctors would actually be doing. Could we possibly combine some of what I call this more predictive AI recommended tools with generative AI tools as an adjunct towards doctors for their decision making? So yeah, that's a thread that excites me, but again, would love to get John's take here.
And there's a lot of follow-up questions, right? We did this study for diagnostic reasoning, but we've also have one that's in review right now that's around management reasoning. It's not just do you think you know what the diagnosis is and how do you reason, but what would you do for this patient? Do you think this is worth the risk or not? How would you communicate with them? And the preprints out right now. The chatbot does help the doctors do better than it was, but it still didn't do better than the chatbot by itself. And we have even more preliminary stuff that we can't say too much about because it's in the early phases, like we were studying basically GPT-4. That's like last year technology. That's pretty stale at this point. We've used more updated versions, and Chatbot alone is dramatically improving substantially. We don't want to say too much yet because it's on the horizon. And it really begs the question, what's the right role for humans versus computers and the right way to combine those? So other things we're doing is like dissecting the chat logs, because clearly, is it that the computer is smarter than the human and so we shouldn't combine them? That's obviously not actually the answer. But what it means is like there's a whole new type of technology. It's like the internet just got invented. We don't know how to use it properly yet. A lot of the problems last year, doctors were treating the chatbot like a search engine. That's not what they are. A lot of them didn't realize you can just copy paste in a whole case and get information and very robust answers back out of it. So dissecting the chat logs, interviewing people, understanding their concerns, their availability, and understanding new ways to really train and retrain an entire generation of the healthcare workforce is what's needed next.
So I'm glad you brought up the point. That was part of my next question about training the next generation. So, Jonathen, what do you tell your students in coming in about these new AI tools? Do you recommend that they use them?
What I say is, whether I recommend it or not, I know you all are using it anyway, right? There's such a 90% of students. The teachers are, oh my gosh, ban this technology. We can't let our students touch it. Even if that were a good idea, it's unenforceable. 90% of students are using it to do their homework and their take-home exams without even attempting to edit the answers. I had some medical house staff, I was teaching them about what this technology was, and they stopped me halfway. Wait, what? We are totally using chatbots in ICU rounds right now. Are you saying we can't use this as a medical reference? I'm like, no. You should not use it as a medical reference. Doesn't mean you can't use it. You can and probably should use these tools. Just understand what they are and what they are not. And a reference is just not what they are. They're incredibly robust at understanding language and what appears to be reasoning, brainstorming, practicing dialogue, really powerful, but they cannot be a reliable source of reference information. So a key topic I talk about is confabulation, hallucination. These things are remarkably robust and only getting better, but they also just make stuff up. And the problem isn't that they're wrong sometimes. Lab tests are wrong sometimes. Humans are definitely wrong sometimes. The problem is they sound so convincing. They confabulate so well. Like your patient has an alcohol problem, Wernicke-Korsakoff syndrome. It sounds fluent until it's only if you double check, wait a minute, that wasn't actually true. That didn't make sense. As long as you're vigilant about that, understand what they can and can't do, I think they're remarkably powerful tools that everyone in the world needs to learn how to use.
So then, Ethan, is that correct? Are 90% of your peers using these AI tools?
Yeah, that's a great point. I think lots of my doctor friends I know are already using it for one way or another. I think there were a few surveys put out by BMJ, a few others, right, that actually said more than half. I think just to add on to the point that John mentioned, I think we had a very good editor comment, again, tying back to your question about AI versus doctors, about human doctors being the sole reliable backstop. And hence that makes what John mentioned, right, about teaching students about what it is and isn't so much more important, because unless you know what a hallucination is, you're not going to realize that they have their shortfalls and flaws. And if you think back to this whole backstop thing, I think it's true because doctors today, there's so much noise, right? You interpret test results, a nurse brings things to you. And then how do you formulate a plan above all that noise, right? And if you're just going to click sign off on everything without checking, then often you're going to make, bad mistakes. And I think, therefore, if doctors and students today know better, the shortfalls of these tools, that would better equip them towards working better as these tools inevitably get better and better.
Then, given both of your backgrounds, and specifically Jonathen, what then do you want as safeguards for these new AI tools? In other words, what do you want to say, knowing what you know, to the computer scientists that are developing these type of tools?
Oh my gosh, we only got 20 minutes. Let me try to narrow it back down. Remarkable capabilities. They still don't practice medicine, nor should they. Nobody's going to let a robot take care of a patient yet. So that is this much more relevant question: what happens to give humans access to these tools? What we found is if you just put a tool in front of them, it actually doesn't work that well because they don't really know what to do with it. That we have to figure out how so much of medicine and good healthcare is like that last mile problem, the integration of very complex things. We were just talking about this. The fun decision making, the problem solving is a key part of medicine. Actually, the technology, the AI model is actually a very small piece of what really is needed to take good care of patients. But let's use that piece because that's one of the things we need to do. But realize this isn't like playing Go or chess or something like that. There's like real lives at stake here. When you do something wrong, you hurt people, you hurt them in really bad, nasty ways. That the stakes are high enough, but also the stakes are high if we don't use all the best tools we have available.
I'm not sure if you're alluding to, the likes of Cloud A, OpenAI, what they should be doing. But I think that they're doing a lot of the right things. More recently, Google were one of the first that already have an internal clinician team, but we've started seeing, right, OpenAI start hiring clinicians, doctors, research engineers. And the reason for that is because healthcare is clearly such a big and valuable application. So I do think that is a step in the right direction. And it's also something that I'd like to keep seeing more of, right? More research collaborations, more working closely together with health AMCs, researchers, because that's the best way we could realize some of these benefits while understanding some of the shortfalls.
I would add one quick guardrail in the meantime. Doctors don't just copy and paste patient information to a public chatbot right now. You're actually uploading patient information into a tech company when you do that. There are secure routes you can do it, so interact or use these tools or anonymize them enough to be effective. But that's another key guardrail you have to do. For brainstorming, another really powerful application I found is practicing conversations, tough conversations, and negotiating with a chatbot to see how that goes and see what that conversation can be like. I found that actually quite a very interesting way to have a dialogue. But when it comes down to like a really important decision that depends on reliable information, it probably is right, but go and double check from a reliable source in follow up.
What was the term you used, like the back and forth conversation?
So I wrote a piece. It's called "Who's Training Whom." It was in the Stanford Medicine magazine, where I talked about how I had to talk to a patient's wife. It's a tough conversation. And I went and talked to the chatbot. Hey, chatbot, you pretend to be the doctor. I'm going to pretend to be the patient's wife. And I want to see how you would handle the tough questions she gave me. And the really weird thing, it was actually given some pretty reasonable and very empathetic, thoughtful responses to the point that I felt like it was starting to provide better counseling than I did in real life after a few turns. For a moment, that gives us existential angst. Wait a minute, empathy, personal connection. I thought humans did that. Computers are bad at that. Actually, robots can write more empathetic messages than very busy doctors can. But before we worry about the angst of that, this is very compelling. That actually ways we can train and use these tools to help us practice our most human skills in medicine. In addition to all the very diagnostic medical reasoning, which is a key part of it, I think if we're creative, we can use these tools in many powerful ways to aid us in taking the best care of patients.
I love that example. We did have a study in JAMA that showed that chatbots were more empathetic than humans in terms of like responses rated by providers. So it was really interesting that way. But I love this idea about having a chatbot be trained almost in these conversations or using it to be able to learn. But we know that AI has been around for quite some time. And I think we're always waiting for it to change healthcare. Do you think that this is it? It's going to make healthcare that much better than all the previous decades?
I am genuinely, personally, very, very excited about the ability of this technology. From what I've seen, a lot of my fellow researchers, friends, they are all equally excited. And I think that there'll be lots of interesting things in the next 2-3 years to look out for, whether it's applications, whether it's how to evaluate things, whether it's how doctors and AIs could work together.
If the reality is also one thing, AI means nothing. It's just the marketing buzzwords. Whatever the cool thing a computer does, we call it AI. And we've been doing that for 50, 60 years, right? Now language models and generative AI is what we're calling it. Although this does feel more like a thing you can converse with. So I'm willing. I didn't even want to call machine learning AI back in the day. It is not going to fix anything, but it could enable a lot of new things. Just like the internet didn't solve medicine, but it allowed you to practice in a very different way. When there are patients on multi-month waiting lists, right, who can't even get access to a physician, when we have to fill our days with pajama time, filling out notes and documentation that has almost nothing to do with patient care. Yes, please, AI, get in here and self-automate some of our tasks. I think there's a lot of optimistic potential for what it can do, balanced by industrial revolutions, disruptive new technologies, tends to make us all better off on average. However, it often very leads to predictable harms, disruptive changes, inequities, and biases along the way that we should be aware of so we can mitigate them towards getting to the actual good stuff we're getting to.
Considering your paper, have you shown it to patients and have they now said, okay, I now want AI to treat me?
Yeah, I feel that there was a paper recently put out that did a census poll of doctors and patients, how receptive they are. Don't quote me on this. I felt like it was 50-50 there. And I think that a lot is going to be education on both the provider and patient side on what AI could or couldn't do, right? I think a really provocative question would be, hey, if AI is like in our paper, right? Again, very limited situation, shows that it's better than doctors. The question, would it be irresponsible for doctors not to use this sort of tools, right? And I think in a similar fashion to if I were taking a plane and I know that every other pilot is using some sort of autopilot for 90%, and this pilot comes in and says, I'm old school, no pilots, I'm going to pilot with my manual skills, right? I'm like, hang on, maybe I don't want to get on that plane, right? Give me the other one instead. I think a similar thing we could see playing out in healthcare. But when it comes down to it, like John said, whether it's the internet, I just see it's going to be a tool. It's going to be, hey, technology has moved from horses to cars. This is just going to be an evolution, right, of doctors first using stethoscopes and different type of tools.
What is going to be needed more than reasonable is it just has to have the earned trust. There's clearly very compelling potential here, but also a lot of predictable harms that come along the way in terms of privacy, access, bias, etc. So when the technology's earned the trust, I think it will be more or less expected. Sometimes when the patient comes to my visit, I kind of want to quickly look something up, but I don't want to look dumb in front of the patient. I had to look something up, but actually maybe the patients would like that to show that you're using every tool available once it's shown to be credible enough. And there are approaches like what we did, a prospective randomized study. That's how you deliberately answer questions. You don't just guess if it makes a difference or not. And then there's going to be this tension, and I think there's a lot of disruptive potential. What is a medical encounter? It's doctor plus patient in a clinic room. That clearly cannot be the way things sustain at this point. And for better or worse, it's probably happening already. Patients are going to reach for a chatbot that's 24/7 available all the time, even though it might not be as robust. It might not have as good judgment. It might be a little bit off compared to what a human clinician can provide. But a human-driven workforce, we can never keep up with the demand of all the patients who need us. So they're going to reach for it one way or the other. We'd better figure that out as a medical community so that we can actually meet people where they are.
How do we get the public to trust AI in healthcare?
I would say our studies are not enough yet. These are canned patient questions, clinical vignettes, are prepared, directed sample, very powerful, another key stepping stone. But eventually, there is a way we can answer things in medicine. Does anybody know how Tylenol works or anesthesia works? I have no idea how that works. Nobody knows the mechanism, but we still use them because they've been proven safe and effective. We have a way to do that, which is deliberate randomized controlled trials in real settings. When we have that, I think patients and clinicians can feel more confident about that. And we're building towards those steps, but there's just a lot more involved to figure out how to do it definitively. Also realize that medicine is so big and complex and dynamic.
Jonathan and Ethan, would either one of you want AI as a doctor?
Yeah, I think that depends on how well it's implemented. I think it devils in the details. I think if there could be a model that if, I'm waiting time is going to be 3 months, right, to see, and hey, this is an intermediary thing, perhaps. But again, it really depends on how it's executed. And, I think even recently my sister was like, oh, I've got this rash, photo, one line. I was like, hey, I put it into Cloud A. I copy pasted, give it to her. She was like, I don't like that. I could have done it myself. Then I was like, all right, 1, 2, 3, 4, 5. Actually, 3 and 4, the steroid, watch out, this stuff. And then she was like, that's what I want. So I feel that there will always be an element of that. But again, it depends for, again, what purpose and how implemented.
I've totally used these things for medical questions for my patients and my own family. I don't have time to make an appointment with an oncologist. Let's just see what it says about this. Not because I'm relying on it as a source of truth, but as a dialogue partner. I practice conversations with patients, business negotiations with my wife. Let's just see how this goes. And you know what? You're not being tough enough. Act a little bit tougher. Let's see how this conversation goes. I've used it in many different settings, not because I rely on it. I have had people who they think it's like God. They think it's like the oracle and it has the answer. That is not the correct answer. It's okay to talk to it, but you can't rely on the only source. There's still many compelling ways you can use it.
I've never thought of that in terms of using it as a conversational tool, but I actually love that. Well, thank you very much for both being here. Let me ask you both, is there any questions that you would like me to ask?
I just usually end with now instead of the theorem of informatics. The usual quote I end with now is Kurt Langlois, one of my colleagues. He would say, look, AI is not going to replace anybody, but those who learn how to use it may very well replace those who do not. And I think that's a space we're in where let's be on not just developing technology, but reframing how we think about how to use these tools effectively so we can actually reach all the patients who need us.
Well, thank you again for both being here. And I look forward to the new studies that you have coming up.
No, thank you for the great questions.
Won't be the last time. Great to meet you, Yulin. We've got a lot more to follow up. It's a very dynamic space.
I am Yulin Hswen, Associate Editor at JAMA and JAMA Plus AI. And I've been speaking with Dr. Jonathen Chen and Dr. Ethan Goh about large language models and its influence on diagnostics. You can find a link to the article in this episode's description. And for more content like this, please visit our new JAMA Plus AI channel at jamaa.org. To follow this and other JAMA Network podcasts, please please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Moreau at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.